Thank you to all the presenters. They did an excellent job today with presenting the sessions that we have posted for you guys. So right now we want to run through some of the question and answers. There were a couple of questions that were sent through the questions and chat box. So we'll go ahead and begin that Q&A session. So for the first question that we have that was asked, this is directly asked to Dr. Okeke. So the question is, can you go over the workflows again, explaining the care team roles?
Yeah, thanks for the question. So let me provide some background, I guess, before we talk about the workflows again, especially for practices that are using or selected or opted to use CTOs. So there is a CTO practice arrangement that was signed between both parties. And in there, the initial work was done to identify for each of the different functions and indirectly tied to requirements, what would the CTO offer to support you? So I think that's where to start in order to identify at least what needs to be done and who can you have on your care team. What can the CTO offer you, and what can you get more of? So with your CMF funds, if you can hire more support resources, as well as add that to the resources that the CTO will provide, then that's where you start. So first of all, identifying the what needs to be done, identifying the resources that you have with a good dialogue with yourself and the CTO, or if you don't have a CTO, then you can determine based on the additional funds you got, where are the gaps? And you may not get that right the first time, so it will take some iterations for you to get to where you want to be. So when you do that, then we now can do a deeper dive to look at the workflows, because now you have identified what needs to happen, you've identified the resources you have. So as you start working through what needs to be done, it's very clear to see what the gaps are. In a case whereby you start with making do with what you have, then you have to focus on what the handoffs are. So if, for example, you have determined that you would have one of the MAs in the practice to be the ones to focus, on looking at the outreach for patients who had a recent inpatient admission or inpatient discharge or ED visit, then at least that's dedicated to them. And just what you have to be mindful of is the volume, right? So this is going to vary by practice. So if that one person can handle the volume on a daily basis, then that's great. If it's too much, should you ask somebody else to support? And this particular MA that you're assigned to support with this, do they also have to run patients or prep patients, room patients? What does that look like? Do they do this first thing in the morning, last thing in the evening? So these are all the things to kind of consider as you begin to think through coming up with a workflow that works. For the lead care manager, I always would think of it this way. The name lead is there for a reason. They are leading something. So they are leading the charge for your practice for care management, which is, as you have seen in this presentation, it's kind of broader than just a one, track thinking. So they are supposed to be kind of overseeing the care management, care coordination for your practice, and they will be supported by the MA or any other support care manager or care coordinator in a way that makes the most sense, so that you can have the lead care manager focusing on the very high risk patients that need long-term care, but at the same time kind of helping with guiding, in some ways with other rising risk patients. Because what we don't want to happen is focus on the high risk patients and forget that some folks who are rising risk are ignored and end up becoming high risk. So where the support care managers and the MAs and stuff can also do a bit more with supporting your mid risk tier patients. That's helpful as the lead care manager is leading the charge in high risk patients, and then pulling in the CHW when needed, pulling in the MA when needed, and things like that. All this again should be articulated in a plan, in a care plan that should be found in your EMR. So I hope that kind of gave some insight into how to think about the workflow. Until you have those, different components put together, then it makes more sense. And please, if you have any follow-up questions, please reach out to the PMO office, and we'll take this back as well as another topic to kind of have maybe another 1-hour webinar just to discuss that. Thank you.
Great, thanks for that. All right, so the next question that we have here, which I think is a good one. What can you do when leadership is not as supportive with change?
Oh, I would have thrown that to you, Ashley, or or Angelica. That's a good question. We talked already about the change journey. We talked about change resistance. So when your leadership is not as supportive, I want you to, and I don't want to sound like I'm selling a soft skill here, but it's true. You want to rise above it to a place of empathy where you want to understand why. What stage of change is that person in leadership is, and see how you can come up with ways to make your case, if that makes any sense. So I think one thing that helps all along, at least from my experience, throughout my career journey, is if I had something that I felt could be done better, and I had superiors or my boss who I thought I would want to pay more attention to what I was saying, I tried to see how I could put the numbers together so you can work through with your teammates and say, I've been observing, patients waiting in the waiting room for X amount of minutes, and I know if only the front desk staff and myself can do some things differently, that would reduce wait time. So just having some more tangible examples to make the case for why you think you expect them to be more engaged can be very, very powerful and helpful. Now you can see you have more than enough, performance reviews with all the crisp dashboards and things that you can collect on the side. So again, see how you can discuss as a team with another care team member as well to articulate what the benefits would be had you had the leadership support, and hopefully that would help.
Great, thank you for that answer. All right, so next question we have is specifically for Ashley. So the concept of CHW is new to me, and can you share more about the process involved to establish these services?
Sure, absolutely. So the community health worker role in and of itself, of course, is a group of really frontline public health workers. These individuals have been trusted by members of their community. They've built relationships. They've a lot of times served as a liaison, a link really in between healthcare and social services in the community. So just to kind of put a definition on what the community health worker is, I know I didn't really focus on defining the community health worker. I just wanted to kind of put emphasis on that. And then the process for getting a community health worker on staff, of course, it's going to be different for every practice. But with the community health worker workflow that was shared earlier in the presentation, we see that the entire process starts off typically by the community health worker staff getting a referral for a member that is a patient that is in need. So if at any point there is a patient that needs to have some barriers to care addressed, maybe just be assessed for safety concerns within their home and just the ability to get to and from, that is the perfect time to get a community health worker on the care team, get the community health worker in there really working face to face, hand in hand with the patient to really meet those social needs that are identified from a non-clinical standpoint. And that's kind of just how the process starts. Of course, the workflow, like I said, is going to be different for every program, but the process typically starts with identifying a patient that has some social barriers identified or that need to be assessed by the community health worker. So thank you for your question.
Great. Thank you, Ashley. Excellent answer. Okay. So this next question, I think it's a good one as well. So with having social distancing in mind and challenges for video connectivity, some patients, they just can't manage it. Is there a presenter today that has actually conducted a virtual PFAC? And if so, can you please describe the virtual coordination process and describe the virtual PFAC end results?
I can speak to how you would approach that. Not that I've done one directly, but I've done so many other things that I had to reach out to participants and see how we could do it in a virtual way. So for those who are new to the program, the first step, I believe, if you remember what Ashley walked through, was to identify which of your beneficiaries, will be actively interested in joining the PFAC, meaning that they're able to speak up and share feedback and all that stuff. And most times the primary care provider is able to tell you which of their patients will share their opinion. So I think that's a dialogue that can happen internally, just to identify, say, 2-3 people who can speak up and share what they think, and caregivers as well. And then once you identify them, it's easy to go through the same steps that you normally would have, which is, share with them what the PFAC is about, share with them, how you're putting together an agenda, the different, I guess, policies that will guide the team when they come together, make sure they understand that this is a shared decision-making process that you guys want to initiate. And once you do that, you can, use telephonic means to, reach out, call, and engage them. It will take a couple of calls to kind of get that all established. And then you guys would choose a day that you would actually have the PFAC meeting. And if you have any documents to send by email, no PHI, just like a simple agenda. And then they know that, okay, this is what we're going to do when we have the conversation. And then people use a lot of alternative virtual visit options besides your EMR virtual video conference capability, so Zoom or Teams. With the issue about Zoom, people are kind of skeptical about that, so I'll prefer you use Teams. Doxime is another one that's popular. So how can you have that same virtual visit with 5 people or so who would be on the team and still conduct the PFAC as you would had they be in person? So I think the biggest thing is the pre-work before the fact, and that starts with, you already know who is on the care team who would be a good member of the PFAC. You can discuss with the care team, the primary care provider who would be actively engaged in such conversations, identify the key things, especially MDPCP and the changes that you intend to implement. Should be on the agenda item. Tell them what you're thinking about doing. If you want to enhance communication through the patient portal, whatever the case may be, give them a chance to give you feedback. And then after that, the next meeting should be a follow-up as to how you implemented their feedback, so that they feel that, yes, because we gave you this feedback, you actually did it something one way or the other. Another one with COVID-19 pandemic, you have more than enough resources that have been sent your way in terms of preparing the waiting area, how you want to schedule patients coming in and out. So most practices are doing this, without remembering that they could actually have that as a topic for discussion with your patients, so that you get feedback from them as everybody's trying to be safe and practice, good physical distancing, I want to say, instead of social distancing. So think about that as well, because this will be a good thing to hear feedback about how patients feel about the changes that you will make now and continue to make in your care transformation journey. I hope that answered your question or gave you at least some insights.
Great, thank you. And these are all great questions that everybody is having. So thank you for the questions. In the interest of time, let's go ahead and cover off on one more question, because there are a couple things that I wanted to go over before I turn it over to Dr. Okeke for the closing remarks. So last question, with the warm handoff, how practical is it to implement in a small practice?
Okay, I'll take that one too. So with a warm handoff, so what you saw in the video, yes, it was a video, and sometimes, you know, it looks as though it's something that is a make-believe or a wishful thinking, but it depends on what your practice is doing, and it's different across the board. So there are practices that already do the warm handoff that way, but as you can see, what it would entail is that you do have a more dedicated MA supporting the primary care provider, and that way, when they're rooming the patient, there's all this information that's gathered about allergies, medication review, presenting complaints, and ROS. So while all that is going on, you know, and then the physician is ready to meet with a patient. Typically, what I see more often done is that the MA leaves and the physician comes in and has to log into the EMR, whatever. But think about another option where there could be a warm handoff. So the MA can still continue on being in the room with the physician, and you can see that dialogue going back and forth, pretty much summarizing what it is using the SBAR methodology to share what the situation is, the background awareness, and things like that to the physician about that particular patient in that moment. And then he can, or she can then move on with doing the physical examinations, and then, you know, on determining the best disposition and a treatment regimen for the patient. So I would, you know, say to you that it is practical. There are practices that do it this way. If you need more kind of hands-on learning, we can reach out to those practices to say, you know, do you want to share more about how you do what you do, or do you want to, you know, have more tips or tricks that you can share with others. Connect is a very good hub for, you know, people sharing their thoughts and things like that. So that's what I would say, that it is practical, it is feasible, but I mean, think about it as you go through your change journey, because it will take some modification to your staffing model to be able to do that.
Great, thanks. So I know there were a couple of other questions that were asked in the question chat box. So I'm sorry we couldn't get to those. We'll be sure to circle back and provide an answer to that in a FAQ document or follow-up email, the follow-up email. So thank you so much for attending the webinar. Only a couple more minutes before we let you go so that you can enjoy this beautiful day. So hopefully you did find the training session and the topics that we shared helpful. Before I turn it over to Dr. Okeke for the closing remarks, a couple things I wanted to provide a reminder on. So first, I want to apologize to those that might have been having issues with downloading the handout document. So again, everyone will receive a follow-up email, and it will include a few items. We'll make sure to include a copy of all of the materials, and make sure that the links to the videos that were shared in today's training, you will be able to access that through the PDF document. Those links will take you directly to the videos that were shared. Also, for the follow-up email, we will also be including a link to a post survey. Please take some time to fill that out. We really want to know if the training was very helpful to you. In addition, we want to know what other topics you might want to see in the future. Last thing, look out for the instructions and the link to apply for the CME credits. So that will be provided to you in a follow-up email as well. So those are all the things that I wanted to remind everybody about. Again, I appreciate that you guys stuck with us, and hopefully this training was helpful. So I'll turn it over to Dr. Okeke for the additional closing remarks.
Okay, well, thank you, Angelica. So everyone, you cannot be thanked enough for the work you do on a daily basis. I know we're all stressed, we all work hard, but where you have to wake up every day and not just think about your own self and your family, you have to think about your patients and their life, and their welfare and how they're faring in this time. It's a lot. So please hear us when we say that we appreciate you and we're so happy that you make the time to come here and learn how you could do more for your patients, especially through the MDPCP program. So as Angelica said, we will continue our work through the PMO for MDPCP to support the best way we can. And if you have any questions, please know you have resources, more than enough resources to support you. Please reach out to your state practice coaches, for those who have CTO, your CTOs as well, and you should get an answer, right? Again, leverage the Connect as pretty much a peer-to-peer collaborative that you guys can use to share different initiatives and ideas that you have as we go along. So thank you so much for your time, and I hope that we can see you guys sometime soon. Thank you.